Okay, ladies and gentlemen, welcome to another sessions of Mosul second conference for dental sciences and oral maxillofacial surgery. In this sessions, we will talk about the impressions material for the removable prosthodontic. It will be presented by our speaker, Dr. Paul Hyde, who is associate professor at Leeds Dental School. So please welcome with me to Dr. Paul Hyde.
Thank you very much. Well, it's a real privilege to talk to you in Mosul about dentistry, and thank you for asking me to give this talk. Thank you for the postgraduates in Leeds who have been in contact and have invited me to do this talk. I am going to talk about a number of things about removable prosthodontics this morning. I'm going to start off with the academic background to impressions for partials and for complete dentures. And then I'm going to move on to some research that we've done about which is the best material. And then we're going to come back and talk about more research on pressures within impressions and what we're after when we're moving forward, and how we can use differential pressure techniques on some difficult patients. So it's a rather long introduction to what I hope will be useful clinically to you as you practice dentistry out in Iraq. So first thing is that impressions for cons are a different thing to impressions for prosthodontics. An impression for cons are very easy, mainly because we normally just want an impression of the teeth if we're doing cons impressions, and teeth are hard tissue, which usually they don't move unless you've got periodontal disease, of course. But usually they're hard and they don't move, which is different from prosthodontics because we need more in prosthodontic impressions. We need edentulous saddles and we need the sulcus. And we want the full extent of the denture bearing area, and we want the functional depth of the sulcus recorded on our impressions. And these are soft tissues. And unfortunately, they have the tendency to change shape and move when we take an impression of them. So they are unusual and different from cons impressions, and it is impressions of soft tissues which make prosthodontic impressions worth considering. So prosthodontic impressions are all about controlling the soft tissues. I'm going to talk about these 6 things in the first half of this lecture before we get on to some practical tips on taking impressions for complete dentures. First of all, we're going to start off with anatomy, so let's talk about that. If you want a paper on anatomy, the best one I can refer you to is a long time ago, that's over 70 years ago, isn't it? Boucher, American Dental Association. Boucher was the original editor of the Journal of Prosthodontics, and his textbook is still used by most US dental schools, although it's been edited and changed. But Boucher's Complete Dentures is the standard textbook still in the United States, and his looking at anatomy of the denture bearing area is still the standard dissection of the denture bearing area of the mouth. Well, let's talk about it. The lower denture bearing area is defined by the muscle attachments. The buccal side, it's the minimum depth of the sulcus we want, and as you know, the buccinator insertion and the external oblique ridge defines the buccal border. Anteriorly, it's the mentalis muscle, incisive muscle, particularly the mentalis muscle. We'll come back to that. The buccal shelf is important for denture bearing area, just as the palate is in the upper arch. Lingual sulcus, we define the functional depth of the sulcus by the movement of the muscles there. It's not the minimum depth of the sulcus on the lingual side, but the functional depth that we're after. So that's fundamentally different. Buccal side, we're after the minimum depth of the sulcus on our impressions. On the lingual side, we're after the functional depth of the sulcus. The mylohyoid ridge and the mylohyoid muscle attachment there is a problem for us on the lingual side, and we normally want to extend beyond the mylohyoid ridge into the retromylohyoid area to get some lateral stability to our dentures down there. We want to go back normally as far as the pear-shaped pad. We don't normally cover the retromolar pad. Some of the older textbooks talk about covering the anterior third of the retromolar pad, but that is what we now call nowadays the pear-shaped pad, as you can see on the diagram there. The upper denture bearing area is a lot simpler. The buccal sulcus again is, we normally want to record the minimum depth of the sulcus buccally, and that's defined by the muscle attachments. In addition to that, we have a hard palate which we want to record as far back as a couple of millimetres in front of the palatine fovea and as far back as the hamular notch. The vibrating line can give us an indication, if we can't see the palatine fovea, of where we want to finish the denture on the palate. And the frenal attachments are something which we need to pay special attention to. Frenal attachments move, and we want to be able to record them in all their possible positions. So this frenal attachment will move backwards, and frequently on impressions you see them frozen in one position, pulled backwards into what I call the grimace frenum. But it does also move forward just as far, and in function when a patient is smiling, grimacing, talking, moving, blowing kisses, the frenum moves forward as well as backwards, and when we take our impression we want to move that frenum dynamically so that we record all possible positions of that frenum. That's a common mistake on impressions, to record the frenum frozen in a single position. Another consideration in the upper arch is the position of the coronoid process of the mandible, which is the limiting factor to the lateral movement of the chin. If you open your mouth 2 millimeters and try and move your chin a long way to one side, what stops that movement is the coronoid process hitting your teeth. So just practice doing that now as you listen to me, and you'll see that that changes the width of the posterior upper sulcus. And it's usual then, when we want to record the width of that sulcus, where we might want to put a flange of our denture, to get the patient to wiggle their chin from side to side as we take the impression. So all the features that we've got on this on this diagram are important to us, and I'm not going to read them all out, but each one of the items moved we want to record in our impressions. So that's the anatomy and the extent that we want to record when we're taking prosthodontic impressions. Let's move on to some of the work of Hyde, who's looked at the physical properties of the denture bearing area. And the physical properties, if our impressions are all about controlling the soft tissues, then we want to know what are the properties of these soft tissues. The depth of the oral mucosa was looked at by Hyde, and he looked at that quite well in terms of he looked at the depth of the oral mucosa. He did it with ultrasound, which back in 1971 was quite a novel way of doing it. Ultrasound then had only just been developed, and he used ultrasound to look at the depth of the oral mucosa. It has been confirmed by some later work this century, by this chap, but he used a sharp probe to measure it, which isn't really quite as sophisticated, but nevertheless they confer. And the point I want to make is that there is difference in thickness of the oral mucosa across the palate. So we have a thicker oral mucosa in some areas and a quite thin, 1 millimetre thick oral mucoperiosteum in other areas. And that difference in thickness also relates to a difference in compressibility. The thicker it is, the more compressible it is. And the other thing we need to look at, and again it's kids' research is really quite interesting, is the viscoelastic nature of the oral mucosa. And his series of publications over his lifetime are worth looking at if you want to investigate the physical properties of the oral mucosa. I'm going to draw your attention in particular to this schematic diagram of some of his results. He's taken a ball bearing and pressed it into the oral mucosa. And as he presses it into the oral mucosa with a constant force, the mucosa is compressed. And that compression of the oral mucosa flattens off eventually. It can't be compressed much more. The interesting thing is what happens when he takes the ball bearing pressure off. And the recovery of the oral mucosa, if we follow the red line here, comes back up to about 85% of the thickness it was before. And that happened wherever he tested the oral mucosa, and indeed wherever he tested the skin over bone, etc., etc. So it doesn't bounce back like an elastic material would. So if you take an impression, it only recovers very, very slowly this last 10-15% of the thickness. So it's actually hours later that it's getting back up to the original thickness. And that's an interesting and important thing. The compression of the oral mucosa is viscoelastic, so your second impression will not be of the tissues in their resting position. It will be an impression of distorted mucosa the second time you take an impression. The other thing to say from this is if the patient has been wearing a denture which has compressed the mucosa, then the impression that you take will record the compressed position. And we quite often see this in the labs and in the dental labs where the post-dam is recorded on an impression of the complete denture because that post-dam, even though the patient has taken their denture out 10-15 minutes before we take the impression, the mucosa has not yet recovered. And the impression of the post-dam recorded reflects this issue. What's the difference between the red line and the blue line? And its age. This is a young patient, this is an old patient. And the lack of elasticity in our older patients exacerbates this problem. And of course most of our edentulous patients are old. So we have edentulous, an age-related problem, and most of our patients are in this category. So this work from Kidd over a quarter of a century ago, indeed longer than that, is an important principle for us to get our heads around about how we're going to take impressions. The other thing that we want to talk about when we talk about the physical properties of the oral mucosa is the depth and width of the sulcus. The depth of the sulcus is easy to understand. We talk about the functional depth of the sulcus. The width of the sulcus is an artifact. As you're sat there listening to me, your cheeks and lips will be sat against your alveolar ridge and your teeth. There will be no natural width. There isn't a gap between your lip and your teeth. There is no width naturally to the sulcus, and we only have a sulcus on our dental casts because we've created one. We've created one by putting into the sulcus some impression material and widening the sulcus. So the functional depth of the sulcus and the width of the sulcus move when you take an impression. They change shape when you put impression material in there. What we want to do is control the changes in shape so we get an impression of the mucosa in the position we want it. So we need to record what we call the functional depth of the sulcus, and we need to record an acceptable width to the sulcus. The functional depth is determined by anatomy and movement. So the muscle movements and the muscle insertions define the depth. The buccal functional depth is usually the minimum depth of the sulcus. Lingually, it's different. Lingually, the depth is limited by the tongue's normal physiological movements, and I draw a distinction here between the maximum movements of the tongue and the normal physiological movements of the tongue. We will accept a depth of the sulcus normally, which allows the patient to lick their top lip from one corner of the mouth to the other. That would be sufficient movement to talk, speak, move the food around, and normal physiological movements of the tongue without disturbing the denture. If we go further and allow the maximum movement of the tongue, allowing the patient to pull their tongue further out of their mouth, not only is that rude, it is also doesn't allow us to stabilise the lateral movement of a lower complete denture. So the lingual sulcus is an important thing to preserve the flange down there so that we can limit lateral movement. So we'll allow physiological movement of the tongue, but not maximum movement of the tongue. We want to record, another way of saying that is we want to record beyond the mylohyoid ridge into the retromylohyoid area to give us lateral stability to our lower denture. The width of the sulcus is created by the action of the muscles of freedom. There is no natural resting width to the sulcus until something's inserted into it, so the functional width of the sulcus is a tolerated or acceptable width. We normally want our flanges to be a couple of millimetres thick, and we normally want that to be recorded in the impression. So often we see big fat sulcuses recorded in the impression which are distorted, overextended both for depth and for width, and they produce dentures which are unstable. If we use that full depth and width that's recorded on those overextended impressions, we end up with very unstable dentures. Okay, I'm just going to go through some history of impression philosophies. Impression philosophies, there was a great deal of academic argument 70 years ago on these different types of impressions that were taken for dentures. There was a school of thought largely discredited by the middle of the last century on mucodisplacive impressions. There was a new challenge to convention, people advocating mucostatic impressions, and then differential pressure impressions have become more standard, and I also want to mention functional impressions. Let me just go through these. Mucodisplacive impressions are high pressure impressions. Sometimes they're called mucocompressive, but they don't compress the tissue, they displace the tissue. So I have a very old reference there to someone advocating taking high pressure impressions to dentures, and this advocates a high pressure impression, a loaded position. They claimed at the time to give good retention, but in point of fact most of their claims have been discredited, and it's likely to increase pressure at rest under an upper denture, which compresses the mucoperiosteum, which is the main source of blood to the cortical bone in the maxilla. So it is felt that it's likely to increase resorption of the alveolar bone if we constantly keep the mucosa under pressure. So we don't advocate mucodisplacive impressions, with the possible exception of free and saddle lower dentures, which I'll come back to later. Most of the time that type of impression is what we want to avoid. We talk about mucostatic, which was Addison and Page talked about mucostatic. Mr. Page wasn't a dentist, Mr. Addison was. and Mr. Page advocated taking an impression of dentures. Preservation of the underlying bone in contrast to the high pressure impressions. In its purest form, the type of impression talked about by Addison, it doesn't compress the periphery, and it records a knife edge finish to the denture in the sulcus, and as such it often in its purest form lacks peripheral seal. That leads to a lack of retention and any impression. Now, the other thing to say about mucostatic impressions is that no impression is absolutely mucostatic. There is a thought that you could take a truly mucostatic impression of the palate with an intraoral scanner, which may develop and be possible in the future. It's not possible yet for various technical reasons. But you can't, with an impression material, take a mucostatic impression. I've heard it said that if you drip water on mucosa, it changes shape. I think that's a slight exaggeration, but it makes the point that any impression will actually move the mucosa, particularly the sulcus area. Okay, let's move on. Mucostatic impressions are a very useful principle, and it's often an aim to take a low pressure impression to record the denture bearing area, if not the periphery of the denture, with very low pressure. Differential pressure impressions have been advocated for over half a century now. It's a broad term which actually covers a lot of different impression techniques, and one of the problems is that when it was first advocated, there was no evidence that you could actually change the impression within the impression. That's changed now because of the work of so Boucher had it sussed in 1944 that he wanted to do this, but it wasn't until 1969 that Frank published the basic science that showed it was all possible. And that is how to change pressure under impressions, and that was very useful in vitro research. I've repeated that sort of research, and I'm going to, if I've got time at the end of this lecture, I'm going to go through that with you. And I've also published a randomized controlled trial to show that changing pressure in certain areas of an impression is an effective method of producing a satisfactory result for patients. So more of that later. And I think it's useful to know how to change pressure within prosthodontic impressions to change the shape of the underlying mucosa under the denture. Moving on to functional impressions. The functional impression technique is a closed mouth technique in which an impression is taken beneath the functioning dentures. It utilises a slow setting material which is placed beneath the denture, and the patient goes away for a period and it moulds into a functional impression. It's a great idea. Disadvantages: the denture bearing area is said to be recorded in function, and this is said to give a better result in contour when the denture is loaded. But there's no evidence for that. We're not sure that the high pressure bits that we get through the patient chewing underneath the denture are where we want to load the denture. And certainly if we have sharp alveolar ridges or a prominent mental foramen under a lower denture, this technique won't relieve those areas. Indeed, a functional technique may well put pressure on those areas. So we don't choose where to put the pressure with this. One of the disadvantages is we need to have pre-existing dentures. The hygiene problems when taking the impression need to be dealt with. And crucially, we cannot select the areas we want to load with this impression. So it is useful for relines and rebases, but that's about the limitation in modern practice. So some references if you want to go away and look them up. Let's move on to materials, because that's my favourite subject. Let's talk about materials for well, there's several ideal things that we want from impression material. We want it to be light-bodied. We'd like it to be elastic. We'd like it to have dimensional stability. We'd like it to be hydrophilic, because the mucosa is normally wet. We'd like it to have a good mixing time, working time, setting time. Is there an ideal impression material? No, there's not. One has not yet been invented. We have impression materials which are lovely and hydrophilic. So alternate impression material is hydrophilic, but it's not dimensionally stable. We have all the impression materials are elastic. Silicon is hydrophobic. Even the ones which the manufacturers have added things to make them more hydrophilic end up being hydrophobic when tested in the lab. They're just less hydrophobic. Definition of hydrophilic hydrophobic is the angle, the contact angle of water on the surface. If it's more than 90 degrees, it's hydrophobic, and if it's less than 90 degrees, it's hydrophilic. So all the silicon impression materials are hydrophobic, just some not as hydrophobic as others. And that's a potential problem when we want surface detail. So the big question that I wanted to ask is, should we be using alginate or silicon? And to do that, I'm going to now move over to some research which we've done, and I'm going to tell you about research. Okay, let's move on. I want to come back to some of the research we've done now to look at dental materials, and this research we've done it a while ago now, the teamwork involved in running a randomised controlled trial. So this presentation presents independent research funded by NIHR. We got a grant to do it. The views expressed are mine and not the NHS or Department of Health. That's the rider we have to say. When we looked at this issue, in 2002, JOSTA published a review of reporting randomised controlled trials in prosthodontics. And impression materials, there's a lack of sound evidence. In fact, in most of prosthodontics, JOSTA commented in 2002 that there had been a lack of randomised controlled trials in prosthodontics, and prosthodontics largely was expert opinion, which may or may not be valid. At that time, only 2 randomised controlled trials had been reported for complete denture impression materials. Fertel had a go at doing that back in 1992 with a parallel-sided study, but he only had 15 patients on each side, and his outcome measure was the number of adjusted visits, and he found no difference between the materials which he tested. He's unlikely to, with that structure of a randomised controlled trial. First of all, he hasn't got enough patients. Secondly, the outcome measurement, the number of adjusted visits, is not sensitive enough. And thirdly, it is parallel side, which allows loads of confounding factors. There are so many confounding factors with complete dentures that they will confound. So this type of randomised controlled trial, parallel-sided, small numbers, insensitive outcome measures, is never likely to do it. However, I've got to give Fertel some credit here, because that's the first ever randomised controlled trial for impression materials for complete dentures, and he is right in attempting to do it, and it's only with hindsight that I know that these issues make it very unlikely that he is able to detect a difference between 2 impression materials, even where clinically there's a difference. So The point I want to make from that, and indeed from Fraser McCord's attempt at a randomised controlled trial, is that detecting no difference is not the same as saying there is no difference. And that's an important difference to understand. The absence of evidence is not evidence of absence. McCord's trial was a crossover trial. That's a big improvement. But he didn't randomise. He only had 11 patients. And the primary outcome was patient's preference. That's a much better primary outcome. So McCord improved in some ways, but his lack of randomisation and only doing 11 patients was his downfall. He wasn't going to detect a difference with that power. And the lack of randomisation confused the issue. So he, even though it was a crossover trial, and even though he had a good primary outcome, he was never going to detect a difference with those numbers of patients. Both these randomised controlled trials failed to differentiate between the impression materials, which led Carlson in 2006 to say it's not probable that comparison between dentures made with varying materials and methods would lead to significant differences. What he meant then is not probable that we'll be able to tell the difference between these different clinical techniques. And I think that's a very pessimistic view. I think what we need to do is be more challenging in our structures of our randomised controlled trials. So that was a red rag to me. I wanted to prove Carlson wrong and say that we can do good science in prosthodontics. So I want to develop a research question and a protocol which would be able to detect a difference between two sides of a randomised controlled trial. The majority of dentists use alginate as their definitive impression material. The paper I published in '99 shows that. USA is different. They advocate and use silicons, and the papers I've quoted there showed that. So what I wanted to know was which is best. And what I meant by which is best is which produces the best denture for the patient. And the primary objective of the study was therefore to determine which impression materials produce dentures that are preferred by the patients. The secondary objectives were to determine patients' preference for adjusted dentures, patient comfort rating of various things, patient experience of each impression, and we did an OHIP edent of the outcome as well. So we have a primary objective, which is to ask the patient which denture is best, and the secondary objective is to determine various other things which we can come back to and look at differences between the two things, which gives the best denture for comfort, which gives the best denture for stability, etc., etc. So a number of secondary objectives as well. And the trial design, published in 2012, it's a single-centre, randomised, double-blind, crossover clinical trial, alginate and silicon. But that skims over the protocol. Let me just go through in some detail. We had defined inclusion criteria, we had defined exclusion criteria. We had a sample size of 85. The ethical approval was obtained, 85% were recruited. Principal randomisation was a computer-generated via automatic telephone link, and we had a number of randomisations. Let's just talk about what we were doing. We were taking silicon impressions and we're taking alginate impressions. Alginate impression border moulded with green stick. Silicon impression border moulded with heavy bodied silicon, and in the upper arch a light bodied silicon wash. In the lower arch we border moulded with a medium bodied silicon and took a light bodied silicon wash. The quality of the impressions was independently assessed. The dentist taking the impressions couldn't be biased, because if the impression wasn't up to standard, then it had to be retaken. What is important for denture trials, and I can't overemphasize this, is the reduction of confounding variables. And what we went to a great deal of trouble to make sure was the teeth were in exactly the same position, the wax surfaces were copied and kept the same, the extensions were the same, were according to the impressions. So the occlusion was exactly the same, the occlusal plane was exactly the same, the appearance was exactly the same, with the same overjet, same overbite. The idea was, once the denture was inserted into the patient's mouth, the appearance would not be, you wouldn't be able to tell which denture you were wearing. Several blindings and randomizations. We made 2 sets of impression trays which were identical. They were unperforated spaced trays which were perforated at the chair side, and we trimmed the overextension of each tray before we knew which one was to be used for silicone or for alginate. When we made the dentures, the clinician sent off each tray to the lab, and the lab put blue and red dots on the dentures. Half the dentures made from silicone had blue dots, half the dentures made from silicone had red dots. That was randomized, and nobody knew which denture was made from silicone or which denture was made from alginate. There was a dentist who took the denture construction up to trying and then stepped out of the research, and a new dentist and consultant colleague fitted the dentures, and she didn't know which denture was made from which material. The patient didn't know which denture was made from which material, and they were the deciders of the primary outcome. They chose which denture was best. They were blind to that choice. These things are important because they eliminate bias. So over 90% of the patients got through the trial. 53 patients, that's 67-68% of patients preferred dentures made from silicone, while 14, which is 18%, preferred alginate impressions. So not all one side or the other, but there's a large preference there. 4 patients found both dentures equally satisfactory, and 7 found both dentures equally unsatisfactory. That's life, I'm afraid. So the difference here is really quite significant. Count the noughts on the p-value there. It is a big statistically important difference. So when these patients were given these dentures to take away for the first 2 weeks, they were given both dentures, told to wear the red one first day, blue one second day, etc., etc. And at the end of the week, they came back and told us whether they preferred the red one or the blue one. And a huge statistical significance that they preferred the silicone dentures. Not only that. After we'd adjusted the dentures, so we spent 8 weeks just wearing one of the dentures, swapped over, spent 8 weeks just wearing the others, and we made all, during this 8-week period, we made all the usual post-insertion adjustments to the dentures, checked the occlusion, got rid of any overextension, made them comfortable for the patient. And then at the end of that, we gathered the 2 adjusted dentures together and gave them back to the patient. Our thought was that when we've adjusted them and we give them back to the patient fully adjusted by an experienced consultant dentist, they wouldn't be able to express a preference between the two dentures. So we gave them back after adjustment, and we asked them which one do they prefer. And even though, it's important to say, after the first 2 weeks, primary outcome, they've chosen red or blue. We take the dentures off them, and we take off the blue and the red spots. Half the ones that were red we make green, and half the ones that were red we make yellow. And then for 8 weeks we give them the green denture back. Half of those are made from silicone, half of those are made from alginate. So they don't know when we give them back which ones they were. So they can't just, in this secondary outcome that looks at the adjusted denture, they can't just agree with themselves from before. They have to reassess the adjusted denture because they don't know, they aren't told whether the green one was the blue one, etc. So they're blind to it. So they then chose the adjusted denture and they found that they still, although it wasn't as big a difference, count the p-value, count the noughts in the p-value again, it wasn't as big a difference. Nevertheless, they still preferred the silicone after adjustment. We had several assessments looking at comfort, stability and chewing efficiency, and in the unadjusted denture it was absolutely unanimous. For all three things they preferred the silicone dentures. The assessment of comfort, stability and chewing efficiency in the adjusted denture, they couldn't tell the difference on comfort. So our consultant dentist had done their job. They had adjusted the denture so there was no difference in comfort detected. But in stability and chewing efficiency, the silicones were still more efficient and more stable. The E-Dent score followed this, and the adjusted denture were again significantly in favour of silicone. There was no evidence of the crossover. When people do drug trials, they want to have a period after you've used one drug to wash out of the system. So they normally set for crossover trials a washout period between the two sides of the trial. And we looked at whether we should have done that, even though they were randomised, which was first, etc. But there was no evidence of a period or carryover effect, and that's important. The patients preferred the silicone impressions for taste and comfort. Okay, so that's a randomised controlled trial, being very careful not to introduce bias, being very careful to check on the quality of the impressions, looking at silicone, looking at alginate, patients not knowing, everybody blind, second operator assessing the patients, and it's pretty much unequivocal with the outcomes that the statistical strength of the outcomes allows us to make a strong case to say that silicone impressions are better for the patient than alginate impressions. It doesn't tell us, unfortunately, why is that the case, but it does strongly give evidence for using silicone impressions rather than alginate impressions for complete dentures. Okay, coming back to the first half of the lecture, we got as far as materials, and I've just given you some evidence to suggest that we should be perhaps, for our secondary impressions, using silicone impression materials rather than alginate. Let's move on now to talking about impression trays. We'd normally want to use acrylic impression trays. We wouldn't want to be using shellac impression trays because they're not rigid enough. We'd want them spaced for low pressure. We'd want for partial dentures them spaced to allow us to take the impression material out from the undercut. We'd have them unperforated from the lab, and if we were going to put perforations in, we'd do it at the chair side. Perforations do reduce pressure, the uneven loading that perforations give. We use stub handles so they don't interfere with muscle trimming. Our special trays have finger rests. They're adapted 2 mm short of the apparent functional depth of the sulcus on the primary impression. So rigid, acrylic, spaced, unperforated, stub handles, finger rests, 2 mm short of the functional depth of the sulcus. That's our aim for our special trays. And finally, I want to talk about operator technique. Of what I do for clinical impressions now, for complete dentures at least. First thing is primary impressions. I use silicone putty impression material now for my primary impressions in a stock tray. This is a high pressure impression, but we're going to use a space special tray, so these aren't, although they will distort the mucosa, they won't be used to construct the denture. They'll be used to construct a space special tray, which will allow us to do a low pressure secondary impression. But we use silicone because we don't have to adapt the stock tray if we use silicone. So in the old days, we used to, because we were taking alginate, put green stick on our stock trays to adapt them to support the alginate. But the big advantage of silicone putty when it's set is it's self-supporting. So if this was alginate and we poured a cast of that, if it was unsupported by green stick, it would distort by the weight of the plaster. And it can distort a long way. It can distort 3 or 4 millimeters if you don't support alginate that is that shape just by the weight of the plaster you pour on it. So primary impressions, if you're using alginate for your primary impressions, then you need to green stick the edges before you take your alginate. This in silicone can be 1 centimetre, and it will be firm enough when set not to need support. So although silicone is a lot more expensive than alginate for an impression material, it is a quicker technique because I don't have to border mould my stock trays before I take my primary impression. So that's my big hint on primary impressions. The alternative, if the expense of silicone putty is not is a problem, then the alternative would be compo. I have 2 things to say about good old-fashioned pink cake compo. It's a great material. It doesn't do undercuts too well, so be careful of that. You don't want to lock it into hard tissue undercuts. And the other thing to say is that what you need to do with compo is get the material, as you know it's a thermosetting material, so that it feels the viscosity of silicone putty. So, so you heat it up or cool it down in a water bath, add hot water, add cold water, until it is the exact consistency of silicone putty. So compo is a suitable material, and you should consider using compo if you don't want to use silicone putty. Beware of hard tissue undercuts, get it to exactly the right temperature. It's actually quicker even than silicone if you've got your nurse trained to get it to the right temperature. So we normally mark on where we want the special tray to extend to, and we mark on where we want our stops. I don't know if you can see, but this is marked slightly wrong at the back here. This slight undulation here, this slight depression here, is the external oblique ridge, and that extension should go to the external oblique ridge there. It's correctly marked over the mentalis insertion, which you can see on these 2 little dimples either side of midline, and it's extended back to the anterior third of the retimolar pad, now called the pear-shaped pad. I like the position of the stop on this side, on the buccal shelf, between the external oblique ridge and the alveolar ridge. This one's a little bit too much towards the alveolar ridge. So we normally mark them up where we want the stops, etc. Secondary impression materials. We're using silicone materials. These are my stock special trays. So in the lower I have a stub handle, vertical stub handle, doesn't project outwards at all. In the upper arch I don't have a handle. These trays have stops, as marked previously, made in acrylic spaced. I just want to talk about overextended dentures. So this is going back to, I popped this illustration in, to this slide in, just to show that the biggest problem with special trays is they are often overextended. That's because primary impressions are likely to give overextended sulcus. They're a viscous material, and it's almost deliberate to slide up with special trays that are overextended, and the first job is to reduce that overextended. I've got some pictures which show a frenal attachment here and a special tray sitting in that. You can see first of all that that frenal attachment is often pulled back and held in one position. When that happens, you'll notice that the frenal attachment can move a lot further forward. The special tray has been made for that rimis frenum position, which is back there, but the frenum also moves over here. So the whole of this area is overextended, as indeed the whole of that flange is overextended. So the first thing to do is to get rid of it. We test it by popping the tray in, holding it lightly in place, picking up the lip for our border moulding and moving. And if the tray moves when we border mould, then it's overextended somewhere. Be aware of the mentalus insertion. This is a grossly resorbed mandible, and these two prominent lumps on the anterior of the grossly resorbed mandible are bone which has been preserved. And as you know, bone is preserved when muscles pull on it. So when muscles function, insert into the bone, that preserves the bone, just the same as teeth do, and just the same as implants do. They preserve bone in function. So we load bone to preserve it. And these two lumps of bone, and you must have had patients coming in with these in their mouth saying, I think there's a tooth there or something. But these two lumps here are classic normal anatomy mentalus insertions. What we want from this is not to interfere with the mentalus insertion. And a very common mistake is to extend the denture beyond the mentalus insertion to impinge in that area. And we really need to trim that back. So our special trays, we need to have a think about extending there. Which, yes, in this area it can come down, and yes, in this area, perhaps over a frenum here it doesn't, but we can come down here. If we don't do that, then we're very likely to have this sort of problem. This patient is a great denture wearing patient. This patient puts up with the pain of the ulcer, has worn her dentures even though they were overextended on the mentalus insertion, and wears that denture no matter what, and has lived through the ulcer until they've turned into fibrotic tissue. So get rid of the overextension. Then once we've got rid of the overextension and the tray doesn't move when we border mould against it, then we're applying our silicone adhesive. And then in one go we're putting heavy bodied silicone all around the periphery of that tray instead of green stick. This is our green stick equivalent, if you like. And that's extrude heavy-bodied out of a gun, it's just the right consistency, and then we border mould that. And when we border mould that, we may find that some areas the flange is still slightly overextended, in which case we'll trim it down. Where the material has extended onto the alveolar ridge, we need to cut it off just to leave the periphery around there. So we trim it back and we've got the periphery around there. We've reduced that and we've added a little bit of silicone there where it was overextended. So that's our border moulding, and that gives us our peripheral seal. So even though this is a 2mm space special tray, if I put that in the mouth now, that will have suction. And it won't move when the patient moves their lips and tongue around it if they grimace, smile, talk to me, because we've moulded it to the functional depth of the sulcus. I used to perforate, and then I used to take, and then we take a light body silicone wash. So that's the lightest light body silicone that I can find. I fill the tray 2mm deep and I take an impression, border moulding. The lower is slightly different. The problem with the lower is that if I try and border mould this with a heavy bodied material, then it'll spread everywhere. It'll go all over the important buccal shelf and the alveolar ridge, which are our two main denture bearing areas. And if I do that, even though I'm going to come back and use a light-bodied silicone for my final wash, unfortunately I will have changed the shape of the ridge, and because of the viscoelastic nature of the oral mucosa, I won't be able to take a truly mucostatic or relatively highly mucostatic impression of the lower denture bearing area. So what I want to do with my lower denture is border mould with a lighter material. Now I could use green stick, which I could restrict to the edge of the denture better than I could restrict this heavy bodied silicone. But I choose to use a medium bodied silicone in a space tray in the lower arch, which is a relatively mucostatic impression. So I'll put silicone adhesive on and I'll take a medium bodied silicone impression. And that's my border moulding. Normally the stops should show through. This one looks a better impression, but the stops aren't showing through. This is aesthetically a better impression, and it is an impression I can use, but normally I'd expect the stops to show through. And what we do with that then is we reduce the stops to just below the surface of the medium bodied silicone. So I've drilled anywhere actually where the acrylic shows through, and then I'm ready to take my silicone adhesive and take a light bodied wash. So border moulded, light bodied wash. If the stops show through, or if any of the tray shows through, I will drill that away before I take my light bodied wash. And this was one from one of our from the trial. So that's my clinical impressions for complete dentures. I now want to move on to things we can do to modify clinical impressions for complete dentures, specifically for our patients with particular problems. So diagnosing problems on our patients and using the impression to redistribute pressure. Opportunity to selectively load the mucosa within an impression. Putting pressure where tissues can tolerate it and relieving pressure from those areas where tissues cannot bear the pressure. Can this be done? And the first thing we have to do to decide whether this can be done is some laboratory research required to understand what varies the pressure within impressions. And then we have to decide if varying the pressure like that actually makes a difference to the patient. So then we have to run a randomized controlled trial to see if the patients benefit from our selective pressure impressions. By 2008, we performed a series of laboratory experiments which showed the effect of variables on impression pressure. So I'm just going to run through some of those lab experiments very quickly. These were in vitro. We used a machine. We popped a pressure sensor within there, and we had a sensor in the middle of that block, and we put some impression materials there, and we looked at variables that we could alter. So we deliberately chose a flat base to do this on because we wanted to isolate the various variables that affect impressions, and obviously one of them was contour. So we looked at different silicon impression materials and the effect of various variables. And the first thing we looked at was the speed at which we compressed. So we used a medium-bodied silicon, a light-bodied silicon. Between these two, we had a little stop on there to stop it at a known height, and we compressed it. The sensor we used was in the middle there, and we measured the pressure at various speeds. And this was quite surprising that it made such a difference to the pressure. So one of the things which hadn't been reported was how much we compress the mucosa by pressing an impression in very quickly. And if we seat that impression very quickly, despite using space trays, despite using perforations, despite using light-bodied silicon, we will have quite a high impression pressure. And we're talking of a tripling if we triple the... so if we go from 1 second to 3 seconds, we're going from 200 to over 600. So it's not absolutely linear. These are the results we got. But you can say that if you triple the speed, you triple the pressure. And that's quite a significant difference, and the effect that will have on the mucosa. So counting as you're seating the old 1001, 1002, 1003, slow up to 1005, slow insertion of the impression material is a technique which is quite useful when you're beginning to learn how to take impressions. And we got a paper out of that, and that was published in Journal of Prosthodontics. The next thing we wanted to know is it a uniform pressure across the impression? And we looked at the pressure at different points on the impression. So near the middle, centimetre, 2 centimetres, 3 centimetres, 4 centimetres from the middle of the tray. And the distance from the edge of the tray, and this one is in the centre, and the pressure. And again, it made quite a big difference. We're again talking about a tripling of the pressure when we move from the centre, high pressure, to the periphery. So the nearest vent is very different in the upper arch and the lower arch. So in an upper arch, this is a significant thing. So the centre of an upper arch edentulous impression will be high pressure in the middle. And this is something which was known and forgotten about in dentistry. It was very elegantly shown paper back in 1910, which used a series of holes across a disc and pressed compo into it. And a series of holes, the compo was taller in the middle and lower at the edge because the pressure in the middle. And that was a very elegant way of showing this, that the pressure in the centre of an upper impression is higher than at the edge. And that's the reason why people got concerned about the pressure at the centre of upper dentures and did things like put palatal relief chambers to even that out. They got worried about palatal rock, overly worried in my opinion about palatal rock, because I don't find it a problem with low pressure impressions. But throughout the middle of the last century, the academic literature is full of palatal relief chambers, palatal rock and differential pressure impressions to relieve that problem. So the pressure is important. Now in the lower arch, we never get more than 2 centimetres away, so most of the time we're less than 1 centimetre away from the peripheral vent. What this means is lower impressions are always lower pressure than upper impressions, and that's significant. If we take a lower impression, my technique is to border mould with a medium bodied material, and in the lower arch that will be a low pressure impression. We then, having adapted the tray, actually take a close fitting wash in the lower arch, and therein comes a difference. So the next thing to do was to see how far from a perforation, what difference it made to the pressure. So we looked at the distance in millimetres from the sensor, and what we found was if we had a perforation opposite the sensor, the pressure is low. If we blocked up all the holes and had just one near the edge open, the pressure was much higher. Sorry, we're being disturbed again. This is the problem with perforations in a way, is that yes, it will lower the pressure of the impression, but in point of fact they only do it for a very short distance. If you use perforations, you should use lots of them, very close together. Otherwise what you'll do is you'll compress the mucosa in some areas and not in others. Number of perforations of course makes a difference, size of perforations of course makes a difference, but since I don't use perforations I'm just skimming over those. The next one, which is quite important actually, is the space beneath the custom tray. And what we have here is a classic classic shape of pressure which never crosses the x-axis or the y-axis. So if we draw onto here the curve, it never crosses the x or y axis. Let me explain what I mean. If you have two parallel sided plates which are infinitely hard and put something between them, let's say light bodied silicon for sake of argument, and you push them together, the pressure as you get closer and closer and closer gets higher and higher and higher. So as you're starting 2 millimeters away, there's hardly any pressure. You come up, you're 1 millimeter away and it's 100 kilopascals, half a millimeter and you're 300. And it would take, if they were infinitely hard, it would take infinite pressure to get to zero for them to touch. So this never crosses the x or y axis. And we know that from simple hydraulics. So this confirms what we knew. Of course, in dentistry, we haven't got two infinitely hard parallel plates. What we have in dentistry is a hard special tray and a soft mucosa. And what happens if we're using a close-fitting special tray is we're getting very high pressures which distort the mucosa. So the reason you can seat a close-fitting special tray is because the mucosa has changed shape and allowed that material to vent. So close-fitting special trays are always high pressure, and I've stopped using them for that reason. Surprisingly, the medium-bodied, light-bodied and ultra-light-bodied impression materials don't make as big a difference as speed, etc., etc. But the difference in the viscosity of the impression material is a factor, but it's not the biggest factor. Okay, so that's the in vivo stuff. Now, back in 2003, I proposed that it must be possible to take a differential pressure impression for those patients where if you have the sharp bony ridge, if you take a medium bodied silicon impression and you cut away the silicon and then take a light bodied silicon wash, in this case in green, then this area would be lower pressure and it would redistribute the pressure of the impression. So in this patient, and this is a case report I published back in 2003, we had a relief in this area for when the patient was diagnosed with a sharp bony ridge which was causing discomfort under the lower denture. And we produced a denture for her which relieved that area, this area, and gave her a comfortable denture as a result. But that's a one-off case. So after the lab studies, we knew how to do, or we thought we knew how to do differential pressure impressions, but there's a lack of link between what we found in the lab messing around with measuring pressures and what we'd find clinically. We thought this would be possible, but we wanted to show in vitro pressure measurements of this technique, and then we wanted a clinical randomized controlled trial. So in vitro, if we want to, this is a patient who has a prominent mental foramen on the denture bearing area of the lower arch. As you know, as the alveolus resorbs, we end up with the mental foramen prominent lateral to the residual alveolar ridge in the denture bearing area, and that can often be a problem for patients under a lower complete denture. This tray, this medium body silicon impression, has been relieved and a perforation put over the mental foramen, and what happens is that we then take a light bodied wash, and as you can see here, it changes the shape of the mucosa in that area with compression either side of the mental foramen and relief over the area of the mental foramen. When we looked at this in the lab, taking a stone model and measuring the pressure in two areas, one over the buccal shelf and one over the mental foramen, where we've relieved the shape of the impression tray effectively, and we measured the difference between the pressure in those two areas. So we know the pressure's different here, but now having shown that we could change the pressure within the impression in those two areas and distribute it as we thought we could, we then wanted to run a randomized controlled trial to see if we could find benefit to our patients of that. So I'd proposed that method of selecting pressure. In order to run a randomized controlled trial, the first problem was to identify a condition that may benefit from redistribution. And there's a number of possible conditions, but we chose to look at the severely resorbed mandible. So we're talking about mandibles that looked like this, because when the teeth are lost, alveolar resorbs, we get the mental foramen in the denture bearing area. And that becomes a pressure point under our dentures. And in this patient, we have a couple of pressure points there, which when I press on it with my finger, the patient tells me her lip tingles and she has a problem. So what we want to do is we want to determine which impression procedure produces dentures that are preferred by the patient. So you know our protocol now, it's a crossover randomized controlled trial. The The objectives of the study are to provide 3 dentures for each research participant to allow them to choose the denture they prefer. Ethical approval, sample size 65, 69 patients were recruited, randomisation, sealed envelopes, inclusion criteria, mental foramen. Identifying that number of patients who had a mental foramen problem was an issue for us. It's hard to find these patients. The control denture, we made 3 dentures. The control denture was made from a standard impression. The second denture was made from the published technique to deal with mental foramen, which is full relief on your master model. And the third denture was made from the selective pressure technique. Let me just tell you through the selective pressure technique. We took a medium-bodied silicone impression, a light-bodied silicone wash. That was cast up as the standard impression, and then it's a medium-bodied silicone impression with a light-bodied silicone wash. That's my standard lower technique. For the differential pressure impression, we cut away over the mental foramen, we perforated over the mental foramen, and then we take a light-bodied silicone wash. And that's the typical type of impression that we get of that area. We made sure the dentures were very similar on all sides of the trial. Teeth in the same position, patient wasn't choosing for anything else. The hypothesis, one of the dentures would be preferred. Null hypothesis, none of the dentures would be preferred. Primary outcome measure, patients preferred denture, OHIP second. We did a multinomial logistic regression of potential confounders. We did a confidence interval. That's the mean OHIP score. Okay, so the results were age, sex, which denture was delivered first. No diff in the potential confounders, sex, age, and order of delivery. Null model is preferred for further analysis using bootstrap, confidence intervals, and we found a highly significant difference. There was no difference between the foil denture, which is the traditional way of dealing with mental foramen problems, and the control denture. That's just a standard impression with nothing done. There was borderline statistical significance. That confidence interval shouldn't go past 0 for it to be significant, but it just did slightly, so we're not quite statistically significant between the new impression technique and the traditional method. So not much difference between them, but there's a tendency there. But between the control and the selective pressure technique, we were statistically significant. So we have the evidence to suggest that distributing pressure in this way is better than taking a standard impression and making the denture, and we have a hint that if we'd had a larger sample size perhaps, then we'd have been better than the traditional method of dealing with it too. So null hypothesis is rejected and a selective pressure impression is advocated.